Thank you for inviting me to present at this anniversary meeting of the drug utilization program of HERA in Korea. As was just said, my name is Nicolaas Sieds. I'm strategic lead of the healthcare quality and program at the OECD in Paris. And it's a pleasure to share with you some reflection about the use of drug utilization data as a source for quality improvement. But first, of course, I'd like to congratulate HERA with the 10 years anniversary of that drug utilization review program. Actually, I was in Seoul 10 years ago when the OECD was asked to do a review on the quality of care in South Korea. And as part of that visit, I had the pleasure of being in the then headquarters of HERA and visit the system, the computer actually physically, where real-time data on prescribing in the Korean healthcare system were collected. So it's very nice to see that 10 years later, we're having this international symposium to really reflect on the experiences and the lessons that were learned. And I was impressed at that time by the fact that you have a real-time availability of prescribed medications and the potential of using that both prospectively and retrospectively to learn about rational use of medication. So what I will do in this presentation for your conference is basically share the perspective from the OECD as an international organization about the use and the utility of having this knowledge about prescribing data. And one of the things I try to bring forward is that these data only have a meaning when they are turned into information and are actually used by people to change their behavior. And that's done on different levels in the healthcare system. That starts with the individual physician who gets feedback on his or her prescribing practices and learns that certain drugs could better not be prescribed, or sees the long-term effects. Because you will never be able as an individual to learn from only your own experience on what the overall effects of drugs are. So getting this feedback is important. That's the first feedback circle. But another feedback loop can be on the level of your practice, the group of practitioners you work with together to see whether you could synchronize the prescribing practices. And even further, it could be in a regional or local network of different clinics and prescribers that evaluate systematically the use of their medication. So having feedback loops on the individual, the practice, and the local level is essential if you want to add feedback loops on a national level, as is done with the drug utilization review program of HERA. And it becomes even more distant if you try to learn from this data on an international level. Of course, my presentation will be about this international learning and using drug utilization data by comparing countries and hence trying to improve. But one of the main points I would like to make in this presentation is that all these feedback loops are important and should be in synergy. So I already addressed the unique character of HERA's drug utilization review program, which is now in place for 10 years. And as far as I know, there are not that many countries who have similar real-time availability of data. I'm familiar with the Medicaid program of drug utilization review in the US and several European programs that set up the same thing of using the claims data to provide feedback. But HERA is rather unique in the directness of the data. And as you will discuss at your conference, that also proves to be very beneficial in a period like of a pandemic when you really want to have quick information of what's going on and how to react. The high-level feedback loops I will discuss today are a few case studies. I will share with you some of the experience of the OECD on working with, with antibiotics prescribing data. I will share with you the story about opioid use and how to use prescribing data to address that. I will use the case study of diabetes-related medication. And more in general, I will tell the story on how data on prescribing and medication form an important part of our efforts to make healthcare more safe. So the relation between medication and patient safety. And at the end of my presentation, I'll come back to what I started off with, exploring the link of drug utilization data and quality improvements through the various feedback loops in the healthcare system. But before starting with the first case study, let me just share with you the overall framework the OECD is using for summarizing data from countries on topics in healthcare. This is actually the framework that we use for building Health at a Glance, the biannual publication of the OECD that tries to summarize a lot of information on the performance of healthcare systems. And I'm happy to say that in November, we will release the next version of it. But it's good to see that behind that lies a framework that really tries to link the different components of the system. So there's information about the health status, there's information about the risk factors, and when it comes on the actual contribution of healthcare to the health, it looks at access to healthcare, quality of healthcare, health expenditure and financing, resources and activities like workforce and the volume of activities. And we have specific subsector analysis on, for example, the pharmaceutical sector and aging. And all that should be interpreted in the context of the specific demographic, economic, and social context of a country. So when I speak today only about drug utilization data, that should be reflected upon as part and parcel of the broader functioning of the healthcare system. So let me start with speaking about Directional Antibiotic Use. Of course, it's not new to you that we try to rationalize antibiotic use by having guidelines and about prescribing of antibiotics in hospital care as well as in primary care in an outpatient settings. I'm sure Korea is familiar with lots of formularia, local guidelines and protocols that are used to address rational antibiotic use. That's the prescribing side. On the other hand, it has to do with expectations of the population. And here an important part is done by the health literacy of people. Is there a common understanding that antibiotics are no use when you have a viral infection? Or is there a huge demand by the population for antibiotics in situations where, from an evidence-based perspective, it's not really rational to provide those drugs? So we see that there is a need to add to this rational prescribing with national policies. And antibiotics is one of the areas where this has really become a huge international topic, mainly because we can't endlessly go on with prescribing antibiotics and neglecting the resistance patterns that are developing by the overuse. So what the OECD is doing already, I think for 15 years, is asking countries to report the overall volume of their antibiotics. And here you see the data that were presented in 2019. But we try to monitor in the countries the overall volume of antibiotics that are prescribed and the percentage of that are second-line antibiotics. meaning the ones that you should really reserve to really severe cases, because once we develop a resistance against those antibiotics in our healthcare systems, we're out of possibilities. So apart from rational prescribing for the individual patients, is it any use to give an antibiotic to this patient? There is a broader societal problem of when we don't use it properly, we run out of opportunities of using antibiotics in the future. So in addition to the overall data on antibiotic use, and you see some previous data from 2017 here of the data we get from Korea, we also try to to find the percentage of hospitalized patients that have at least one healthcare-associated infection with bacteria isolated. So basically, we try to see what percentage of the isolated bacteria are resistant against the antibiotics. Here you see the prevalence of hospital-associated infections, and the small diamond in black shows you the percentage of the tested tests that showed that the antibiotics were resistant. You see a different pattern, but this, of course, is also important information to monitor alongside the overall volume of antibiotics, the severity of the increase of resistance. The OECD has done a lot of work in the past 6 years on the impacts of at first of the burden of adverse reactions to the antibiotics over time. Here you see in the calculation of the health burden of infections due to bacteria with antimicrobial resistance compared to other communicable diseases. And you see that the burden of antimicrobial resistance, the big column on the left, is almost twice as high as the burden in societies of influenza or tuberculosis or even HIV/AIDS. That made it necessary to raise this also on a political level. And actually, the OECD has produced a series of reports on the request of the European Union, but also on the request of the G20, for which the economic consequences of antimicrobial resistance. And basically, those reports tell the story that if you really take now preventive measures, have a more rational use of antibiotics, that is not only saving lives, but it's also a sound economic investment. Because in the long run, the economic costs of having a huge percentage of antimicrobial resistance and not being able to care for people will have huge economic consequences. This table shows the results of one of those modeling exercises, and it calculated for countries within the EU the number of lives that could be saved per year by implementing systematically the preventive measures. And these preventive measures, of course, include, again, having the guidelines, having rational use of prescribing. And I'm making this point just to show that those drug utilization data on antibiotics are not just telling you what is good medicine for an individual patient, but they are part of a broader societal problem where we have to rationalize the use of a resource that in the long term won't be as effective as it is at the moment. So antibiotic use has become a point on the agendas of policymakers and even of presidents when they meet during the G20, and has been picked up as a major topic that should be addressed in OECD countries. That's the story about antibiotics. Let me now move to the use of opioids. Here also, 2 years ago, the OECD released a report that tells how to address the problematic opioid use in OECD countries. This report was written on the request of Canada, that became, as a country, concerned when they saw the major problems that overuse of opioids was causing in the United States. So this is another area where the OECD tries to collect data. And here you see, for example, a graph on the availability of analgesic opioids in 2 time periods. One of the messages here is that you see that in the rates for Korea are very low, which is positive, but you also see countries here where the rates are very high. And as I said, in the US, this is really labeled as a crisis, the opioid crisis. So that's why the OECD for all countries asks this kind of information. And we, like with antibiotics, we like to see the overall volume of opioids that is prescribed. And here you see a list of these data just to help countries to get an idea where they are in their opioid use compared with others. And of course, as you will find a graph in the report released in 2019, we try to capture the opioid-related deaths between 2011 and 2016, and you see the improvements that were made in the US, the problems that still exist in the US. You also see that in some other countries this is not considered as a major problem, but it just illustrates that rational use of opioids, using drug utilization data to provide feedback on your prescribers and your system, are key in keeping things within the limits of what is rational prescribing. For my third case study, I would like to refer to diabetes care. And here, the indicators on medication use are part of the broader story of how countries are dealing with diabetes. What you see here is a graph on diabetes-related hospital admissions. In essence, these are potentially avoidable hospital admissions. If you treat diabetes patients well in primary care and outpatient care, and they use the right medication, then the chances of them being admitted to a hospital in an unplanned way are, of course, minimized. But we see here that, of course, the overall the situation is improving in the majority of the countries between 2012 and 2017, meaning that increasingly fewer patients with diabetes have an unplanned admission to the hospital. But you see that when I look at Korea in these data, it's still relatively high. So one of the factors that relates to appropriate diabetes care is, of course, the medication. And one of the tables that we present in our Health at a Glance publication is whether people with diabetes are prescribed the appropriate antihypertensive medications. Of course, you can do this when you have a good drug utilization review system in place, because on the one hand, you can take the list of diabetes medication, which is almost solely used for diabetes patients. And then you can see if for those patients in combination, what antihypertension drugs they are having. You see that that's overall, the picture looks positive. You see that that's for Korea, that there might be room for some improvement. So I'm really looking forward to seeing newer data to see whether the type of antihypertensive drugs that are given to people with diabetes are in accordance with the guidelines. Of course, this is only a small part of the overall story of monitoring diabetes. We also have the data on amputation rates and readmission rates, but overall, this is a use of drug utilization data that can be used internationally, and where you can compare your country and your performance with others. So in addition to these 3 case studies on the use of looking at prescribing data on antibiotics, looking at prescribing data on opioids, and looking at prescribing data of antihypertensive drugs for patients with diabetes, let me share some general notions of the utility of drug utilization review as a good component of patient safety. The OECD did a lot of work over the past 10 years on patient safety, and there are several reports, again used at for example, the G20 conference, telling about the impacts of patient safety on the overall economy. Basically, when you see that 1 out of 10 hospital admissions is related to a patient safety incident, and you can calculate the overall economic impacts, and that is a very good reason to say we really should pay attention to safety in our healthcare systems. And of course, medication use is one of the leading reasons for adverse events. Of course, there are many others. I saw some recent studies looking at outpatient care where the major factor was wrong diagnosis, but about 25% of the cases in those studies, which were done in the UK, was related to medication use. So medication use is one of the drivers of adverse events. And as you know, with your drug utilization review program in Korea, the database of the DER is one of the good sources to identify potential adverse events. I've been going over several papers that were published in the past 10 years over your DOR program, and I was happy to see that, especially in the papers that were published in the last years and that summarized the various studies, I see that your system is able to reduce the number of adverse events. Of course, that is a major function. And of course, while the percentages may seem small, the overall effect is very important of using these prescribing data as a real way to providing feedback to providers, institutes, regions, and the country as a whole on the potential adverse events in there. And as you've been doing from the beginning, you look at the drug-drug interactions, you look at drugs prescribed to people who are pregnant, and you look at specific drugs in age groups like elderly people where there is also multimorbidity. That information is key in dealing with patient safety, because we still know that a substantial amount of hospital admissions is related to inappropriate medication use. I find it difficult to give a percentage there. I've seen studies that range from 4% up to 40%. I think in the Netherlands, the studies that have been performed about medication use related hospital admissions end up with about 15%, but it's substantial. There's still a lot of hospital admissions, and I'm sure the same is the case in South Korea, where hospital admission is related to inappropriate use of medication. That means that it's rightly so to put focus on patient safety initiatives that are related to medication use. And that's the case in hospital care, but surely also in outpatient and primary care, where it's one of the main drivers that's where the adverse events result in hospital admissions, but increasingly so in long-term care. So it would be very good to see over the full breadth of the system how to tackle medication-related adverse events and as a topic of patient safety. So this is all to say that prescribing data are an important information source, and I put here the list of Tony Avery because he was one of the first already 10 years ago when you started with your program in the UK to identify a list of the drug-drug interactions that could be identified in the UK system. I've seen similar lists, of course, in the US, and I know that HERA over the years has refined their list also. So using prescribing data as an important source for information to see unwanted combinations of drugs given to people who are pregnant that they shouldn't, and of course the drug use in specific age groups, especially people above 65. And increasingly, I see studies where it's not just everybody above 65, but also people above 70, above 80, or even higher. So the link of multimorbidity and multi-medication use and appropriate use in the elderly is surely an important topic to look at, especially in relation to inappropriate hospital admissions. So I hope with this presentation, I gave you the idea that these data are extremely important. They can be used for patient safety, but they are part of the broader approaches in the system as a whole of improving safety. So it is good to reflect on how the data are used on different levels. Of course, in the end, it's important to know how are they used on the clinical level. This is a figure that OECD uses in its safety reports and making clear that it should be a series of strategies that are really combined and address all the different components. But thinking this through from the perspective of medication use, I would say, how are the drug utilization review data of HERA used on the clinical level? What are the feedback loops there? How do people use this data on a day-to-day, well, not day-to-day, but on a regular basis to reflect on their own prescribing patterns, on the prescribing patterns in their groups? And is there a mechanism, a regular meeting where these data are systematically discussed? Of course, then there are the activities on the meso level of the healthcare system that has to do with the organizational involvement and the infrastructure. I put here the infrastructure of the electronic health record systems and clinical incident reporting. But an important part here is also how these data are linked to other databases. I'm not addressing the benefits of data linkage in this presentation, but my colleague Gillian Odekerk will, in another presentation, show you the advantages of enhanced data linkage between administrative data, mortality statistics, prescribing data, and electronic health records as a very good way to generate the information to put things like medication prescribing in a broader context, link it to clinical diagnosis, link it to the follow-up. And that capacity is an important aspect on how healthcare systems in the 21st century do their work. In that respect, Gillian will also mention that the OECD is presently doing a country review on South Korea on its data infrastructure. And that really looks at the capability of the healthcare system in South Korea to make these linkages and to optimize the use of existing data. And you've shown during the pandemic that several steps can really be made. I'm impressed by the way, for example, how HERA has opened up its clinical database for researchers from other countries to really learn from the impact of COVID. Just to make the point that when you look at the fundamentals, when you look at a national drug utilization review program, it isn't standing on itself. It is part of the broader data infrastructure and the broader infrastructure of reflection and learning, and it should be continuously considered as such. So to conclude my presentation on the use of drug utilization data for quality improvements, the points I want to make, main points are that these data are not a standalone thing. These data are part of the broader data infrastructure in Korea. And that means that linking data on medication prescribing with clinical data, electronic health record data, mortality data, and administrative data is important. The OECD is also moving in that direction. We do a lot of work, and actually one concrete area where we're working on indicators is in integrated care, where we're working with countries on indicators on chronic heart failure and stroke, where the administrative data from the hospital system, the prescribing data from the prescribing databases, and the mortality data are combined. So we basically try to follow patients the whole pathway, and for example, see whether a person with chronic heart failure is on the one hand getting the right medication in time, and on the other hand has readmissions, is stable, and on a population level, whether people die or don't die. So it's research and development, but it's an attempt from an international organization to help countries start looking at pathways of care by really linking administrative data, mortality data, and prescribing data. And the second point that I try to bring forward is that all this data collection should be linked to the various feedback mechanisms. I showed you the feedback loops at the beginning on the level of the individual physician, the practice, the local networks or hospitals, and the country as a whole. But these things need to be linked together. So prescribing data have a direct link with practice guidelines, protocols, performance indicators on different levels in the system, on hospital and regional level, the performance of audit studies to see whether there is compliance with standards, and a lot of feedback systems, not just on a national level, but on the local level. I'm just thinking about my own country, the Netherlands, where the groups of general practitioners in primary care on a regular basis reflect on utilization data. And that's facilitated also by the insurer who helps to collect the data. And there are also on a bi-monthly basis discussions between the pharmacists and the physicians on basically trying to get a better grip on prescribing in outpatient care, in hospital care, and using the knowledge of the specialist, the general practitioner, and the pharmacist to understand whether the medication is used in a rational way. So overall, I'm again congratulating HERA with 10 years of drug utilization review. And I really hope you will have a productive conference trying to see that with the improvements made, you can go even further by linking it to the other strategies in your system for quality improvements. And as such, I will think it's an important achievement after 10 years, but there is a big challenge ahead in the coming 10 years. And I'm looking forward to observe these developments. Thank you very much.